Hello, everyone, and welcome to Global Public Health Week 2025, organized by the World Federation of Public Health Association. This annual initiative brings together institutions, communities, and public health leaders from across the globe to recognize the vital role of public health. My name is Michelle Herrera Corbalan. I'm an intern at the World Federation of Public Health Associations, and I will be your moderator today's session. This webinar is part of Global Public Health Week, and this year's theme, Redefining Equity, Decolonized Public Health for Healthier World. Global Public Health 2025 invites us to reimagine global health strategies through a lens of justice and inclusion. Today's session is titled The Role of Social Determinants in Health, Equity, and Emergency Preparedness. It is an honor to welcome our esteemed guest speaker, Professor Sir Michael Marmot. Sir Michael Marmot has been Professor of Epidemiology at University College London since 1985 and is the Director of the UCL Institute of Health Equity. He is the author of The Health Gap and Status Syndrome and has spent nearly 5 decades leading groundbreaking research on health inequalities. He has chaired the World Health Organization Commission on Social Determinants of Health, served as president of both the British Medical Association and the World Medical Association, and advised governments worldwide on how to tackle health disparities. Among his many honors, he was knighted by Her Majesty the Queen for services to epidemiology and understanding health inequalities, and most recently appointed a Companion of Honor for his continuing impact on global public health. The session will begin with a presentation followed by an interactive Q&A session. So if you have any question, please add them to the Q&A section. Professor Marmot, we are honored to have you with us. The floor is yours.
Thank you, and a pleasure to be with you. So, the role of social determinants and health equity and emergency preparedness. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. We are, of course, very concerned with the health care system, particularly during the pandemic. It brought it all to light. But my concern is with the conditions that make people sick in the first place, the social determinants of health. We launched the WHO Commission on Social Determinants of Health in Santiago de Chile in 2005, and at the launch, the then Director General, J.W. Lee, said the Commission will report in 2008, which is 60 years after the founding of WHO and the Universal Declaration on Human Rights, 30 years after the big meeting in Alma-Ata and the Alma-Ata Declaration on Health for All by the year 2000. And he said, we will be looking for a similar declaration of ringing clarity to accompany the launch of the WHO Commission on Social Determinants of Health. There's our commissioners with, by the time we launched, Margaret Chan, who was Director General, Ricardo Lagos, former president of Chile, was a member of our commission. And we said we wanted to create a movement for health equity. I wasn't entirely sure what a social movement was, but I think we've done it. I think we have created a movement. The language of social determinants of health and health equity we're now hearing all over the place. We put on the cover of the report, social injustice is killing people, on a grand scale. We called the report, the WHO report, Closing the Gap in a Generation. And we put at the heart of what we were trying to achieve empowerment of individuals, of groups, and indeed of whole nations. And I think of empowerment in three ways. Material. If you haven't got the money to feed your children, you cannot be empowered. Psychosocial, having control over your life, having agency. And political, having voice. And we said we wanted to create the conditions for people to lead flourishing lives. In the wake of the WHO Commission, I was invited by the British government to answer the question, how can we translate the findings and recommendations of your global commission for one country, England? And in 2010, we published Fair Society, Healthy Lives, the Marmot Review. I was then asked by the European region of WHO to lead a European review of social determinants and the health divide. I was then invited by the American region, the Pan American Health Organization, to lead a commission on equity and health inequalities in the Americas. And then most recently, the Eastern Mediterranean region. And we repeated, social injustice is killing people on a grand scale. We translated the findings and recommendations for the UK initially in 6 domains of recommendations. I did a follow-up report. So Fair Society, Healthy Lives, the Marmot Review, was 2010. On the 10th anniversary, 2020, of the original Marmot Review, we published Health Equity in England, the Marmot Review 10 years on, to look back at what had happened in the previous decade. And I'll talk about that a little bit. So we had initially 6 domains of recommendations: give every child the best start in life, education and lifelong learning. Number 3, fair employment and good work for all. Number 4, really radical, for a rich country. Everybody should have enough money to eat and pay the rent. Ensure healthy standard of living for all. Number 5, healthy and sustainable places and communities in which to live and work. And we've done quite a lot on housing recently. Number 6, take a social determinants approach to prevention. And the 2 that we've added, tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together. Let me give you the UK context. This is life expectancy for women and for men. I've taken it back to 1999. I could take it back to 1919. Life expectancy for women and for men was increasing about 1 year every 4 years. 1 year every 4 years. Wow. Impressive. And that was true in many countries. In 2010, there was a break in the curve. The rate of improvement slowed dramatically. Then with the pandemic, life expectancy fell. What happened in 2010? We had a change of government in 2010. I hasten to add that I maintain the fiction that I am not party political. I report the evidence, but one has to ask the question whether that change of government in 2010 really led to this slowdown. And the government that was elected, the Conservative-led coalition government, had as its number 1 priority austerity, rolling back of the state, reducing public expenditure. Well, what happened was there was a 14-year period where life expectancy did not improve at all. 14 years. I don't know of another period in peacetime where life expectancy did not improve over a 14-year period. And you can't just say, oh, it was the pandemic, because many other countries did not have a fall in life expectancy during the pandemic. We did very badly. And if life expectancy has not improved in 14 years, something has gone very wrong. The whole WHO Commission and everything I've done since was built on the assumption that health is a very good marker of how well the society is doing. If health's not improving, it means society is not improving. If health is getting worse, it means society is getting worse. It's not meeting people's needs. And if we look by region, it's really interesting. Health follows the social gradient. Classify people by where they live, classify where they live by an index of multiple deprivation, and you find a social gradient. It's not just that the poor have short life expectancy and everybody else is okay. It's a graded phenomenon. Now, the northeast of England is the poor part, post-industrial, Newcastle, Sunderland, places like that. If you're rich, if you're in the least deprived 10%, if you're rich, the regional differences are quite small. It doesn't much matter where you live. Then, the greater the deprivation, the greater the disadvantage of living in the northeast compared to living in London, the rich part of the country. Or to put it differently, the consequences for your health of a given level of deprivation are bigger in the northeast than they are in London. Now look at what happened over time. The dotted line is 2010-12, and then 6 years later, life expectancy in London improved across the gradient. Look at the northeast. The dotted line is 2010-12. Life expectancy fell in the poorest 10%. It didn't rise in the next 10, the next decile, the next. Life expectancy either fell or failed to improve for the bottom 60%, the 60% most deprived in the northeast, whereas it was rising in London. So the inequalities were getting bigger. This is where we were pre-pandemic. Life expectancy had stopped improving, inequalities were getting bigger, and life expectancy for the poorest people was getting worse. And I think that's a statement about society. We did a calculation last year that I'd wanted to do for a long time. People like me are always saying, look at the most deprived and see how high their mortality is, how short their life expectancy is. I said, what about looking at the least deprived? I don't mean worrying about water skiing accidents while on holiday in the Caribbean. I mean looking at health of the least deprived tells us what's possible. Let's make an assumption that everybody, if the social conditions were optimal, everybody could have the low mortality of the least deprived decile. So everything above that is excess. And the greater the deprivation, the greater the excess mortality. We then calculated over the decade from 2009 to 2020, in England, there were 1 million excess deaths linked to deprivation. Wow. What bigger challenge could there be for public health than that? We also calculated how many excess deaths there were linked to austerity, because there was a social gradient pre-2010, but the social gradient got steeper. And we calculated that of that 1 million excess deaths, 148,000 were excess deaths likely because of austerity. One could say, as an approximation, austerity killed 148,000 people. You can see why the people who were in power don't particularly like what I have to say, because I'm saying their policies killed 148,000 people. In my 2010 review, I coined the phrase proportionate universalism. I was trying to combine two ideas: a typical Nordic approach to policy of universalist policies, and a more British approach of targeting the worst off, means-tested benefits, for example. So I said, let's combine them. Let's have universalist policies with effort proportionate to need. If this is the social gradient in health, less deprivation, better health, longer life expectancy. If we intervene only on the worst off, it may be that will improve their health. But what about the people above the threshold of intervention, who have worse health than those above them, but won't be touched by the intervention? So we said universalist policies with effort proportionate to need. What did we get post-2010? We plotted life expectancy for every local authority in England in 2010-12, and then looked at the change in government funding per head of population by 2019-20, in other words, in the subsequent 10 years. The shorter the life expectancy of a community in 2010-12, the steeper the subsequent reduction in government spending. I look at this and think the kindest explanation I can give for this is absent-mindedness. They didn't know what they were doing. But it looks pretty systematic. It doesn't look absent-minded. In what moral universe could this be the right thing to do? The sicker the community, the more money you take away from them. This is the opposite of proportionate universalism. This is effort inversely proportionate to need. The greater the need, the more money was taken away. And when people ask me, why has it been so difficult to reduce health inequalities? Well, this could be part of the explanation. An overall decline in local government funding and central government funding, and regressive settlements. The greater the need, the bigger the reduction. Perhaps that's part of the explanation for the stalling life expectancy, the increase in inequalities, and the decline in life expectancy in poorest areas. Let me think about children. You remember my first recommendation was give every child the best start in life. The Gallup organization surveyed people in 66 countries and asked, do you think children today will have a better, worse off, or roughly the same life to you? The global average, only 44% of people globally think their children will have a better life. In sub-Saharan Africa, South Asia, higher proportions. And you can see if a large number of people are living in poverty, they think, well, it'll get better for our children. United States, 43%. In Europe, it's only around 30%. UK, 31%. Wow. People are saying we have messed it up for our children. And they're probably right. And this has got to be a major challenge for global health. One way of looking at life chances for children, one way, is to look at social mobility, to ask the question, if you're born into poverty, what's the chance of getting out of poverty? Because what we know is, in general, poor parents have children who grow up to be poor adults. Rich parents have children who grow up to be rich adults. Intermediate level parents, intermediate level children. So let's ask the question, if you are born into the 10th centile of income, so low down, bottom 10%, how many generations at the current rate of social mobility would it take to get to the median, the middle? In Denmark, it would take 2 generations. In Finland, Norway, Sweden, 3. Netherlands and Spain, 4. The UK and the United States and Italy, 5 generations. In Brazil, it would take 9 generations. Why these big differences? 2 kinds of explanations. One, the magnitude of income inequality. The bigger the income inequality, the less social mobility. And the second is investment in early childhood. If we look at child poverty rates, UK, Italy, US, Spain, that have low rates, relatively speaking, of social mobility. This is for the OECD countries, so Brazil's not in there, but there's Colombia, very high rates of child poverty. And if we look at the change over time, the UK had the biggest increase of 38 countries. Government ministers in the UK say, oh, no, you're looking at relative poverty. This is looking at children living in households at less than 60% median income. You're looking at relative poverty. If we look at absolute poverty, we're doing very well. Well, it's a very strange measure. They're not doing very well. The Joseph Rowntree Foundation measures destitution. Destitution is defined as doing without 2 or more of housing, heat, light, food, clothing, and toiletries. 3.8 million people living in destitution in the UK in 2022, of whom 1 million were children. For the children, that's a 2.5-fold increase in 5 years. Children being admitted to hospital with scurvy and rickets Victorian diseases. We still have destitution in the UK, and it's been increasing. And I said the other major cause of the differences in chances for young people, for children, is our investment in early childhood. Again, for the rich countries, the OECD countries, the average investment in children 0 to 5 is around $6,000 per child per year at purchasing power parities. In Norway, they spend about 12,000. Denmark, Sweden, France, 9, 10,000. The UK, not so bad, about average, 6,000. The US, 3,000. I haven't got Brazil, but Mexico, much less. Chile, much less. Children today don't have good life chances because of the magnitude of inequality and because we don't spend very much on improving their lives. And look at the US, which looks pretty bad. So public health care expenditure as a percent of GDP, wow, right up there. Medicare, Medicaid, it's a very inefficient system. Total public social expenditure, it's not very high, and much of it is healthcare. Public expenditure on unemployment, US is way down, and life expectancy, US is ahead of China and Brazil and Mexico and Russia and Indonesia and India, but it's behind Turkey and all the other rich countries. So it's not doing well, spends a lot on healthcare, but its social expenditure is not high. It's below the OECD average, and its life expectancy, I showed you those dismal figures for Britain. The only big country that did worse than Britain in that period leading up to the pandemic was the United States. And when we look during the pandemic, change in life expectancy 2019 to 21, so the first 2 years of the pandemic, there's the US, a steep decline. Scotland, Northern Ireland, Germany, England, and Wales. And I said not all countries got a decline during the pandemic. The ones up here did fairly well. And it's interesting, the performance in health during the pandemic correlated with the performance in health before the pandemic. So if we look at change in healthy life expectancy at birth, 2010 to 2019, and the excess mortality as a share of expected deaths during 2020 for people younger than 65. So the UK and the US did very badly during the pandemic, big excess mortality, and we're not doing well. The US was actually had a decline in healthy life expectancy pre-pandemic. The UK had slow improvement. But in general, the better the countries were doing pre-pandemic, Denmark, Latvia, Slovakia, Finland, etc., the better they were doing pre-pandemic, the better they did during the pandemic. I mean, they actually had a reduction in excess deaths, perhaps because people weren't mixing. There was a reduction in deaths due to influenza. And when I noticed that in England, pre-pandemic, life expectancy was stalling, inequalities were increasing, life expectancy for poorest people was falling. And in the first wave of the pandemic, we had the highest excess mortality of any rich country. And I asked myself, what's the link between doing poorly pre-pandemic and poorly during the pandemic? And I'm speculating, but I think the link works at 4 levels: poor governance and political culture. What do I mean by that? Well, in Britain, between the Brexit referendum in 2016, when Britain voted to leave the European Union, and 2023, in that 7 years, we had 5 prime ministers, 7 ministers of finance, 7 senior ministers of health, 10 housing ministers. Utter chaos. The politicians weren't talking about anything but Brexit. Utter chaos. So poor governance and political culture, social and economic inequalities were increasing. There was a reduction in spending on public services. We were ill prepared and we weren't very healthy. One of the things that increases mortality during the pandemic is prior ill health. And that leads to the question, do more unequal societies experience worse pandemics? As I'll say in a moment, I'm co-chairing a global council on inequality, AIDS, and pandemics. And we had a paper prepared for us on precisely this question. And countries with higher rates of income inequality have higher rates of death of COVID-19, of AIDS deaths, and of HIV infection. Look at this. In New York City, pre-pandemic, the so-called Hispanic paradox, life expectancy was higher for Hispanics than for non-Hispanic whites, lower for Blacks. When the pandemic came, it hit Hispanic populations much harder than it did white, and Black were hit very hard. So during the pandemic, you can see these bigger inequalities. In Brazil, white people have seen falling rates of HIV. Black people face rising rates in recent years. And changes in COVID-19 mortality rates from a unit increase in the Gini coefficient by age group. So 1 unit increase in income inequality, big increase in COVID mortality, particularly for younger people, then adjusting for all of these things, relative poverty, median income, which might be part of the mediation. So it's not necessarily right to adjust for all of those things, but nevertheless, it reduces the association, but it's still there. One of the things I had to get educated about in starting with this council, I was used to the idea that almost everything is worse for you if you're poor. But if you look at HIV by country in sub-Saharan Africa, and look at 4 examples, Mali, these are different regions, and the one with the circle is the richest region. And in general, the greater the wealth, the higher the HIV. In Ghana, it's a mixed picture with wealth. These are increasing wealth. But in the richest region of Ghana, the richer you are, the less the HIV. In Zimbabwe, likewise, the richer the region, for the richest region, the richer you are, the less the HIV, and similarly in Swaziland. So you see this changing picture. In really poor areas, higher wealth, higher HIV. In richer areas, higher wealth, less HIV. The patterns changed. Relative risk of dying from COVID-19 among hospitalized individuals in Brazil by a phase of the pandemic. Here we have indigenous people and Black. This is the white rates. And you can see at every phase, indigenous have higher rates of dying among hospitalized patients, and Black as well, somewhat higher than the whites. But social protection can play a role. And we think when we look at social protection, child and family benefits, maternity protection, unemployment support, employment injury, sickness benefits, health protection, old age benefits, disability benefits, and survivors benefits. I won't go into the whole evidence base, but to show you an example from Brazil of modeling, this is what AIDS incidence looks like with no social protection. This is what it looks like with strong social protection. AIDS mortality, the protective effect of social protection. TB incidence, weak, moderate, strong social protection. TB mortality. Social protection can make a big difference. But we are in a new world, as you've noticed. Funding freeze sets off new fight over Trump's vision for his government. Trillions of dollars in federal grants and loans. UNAIDS estimated 6 million more people could die from HIV and AIDS if US funding stops. 6 million people over the next 5 years. PEPFAR, the President's Emergency Fund for AIDS Relief, made a huge difference. More than 20 million people were probably had their lives saved by PEPFAR. In theory, PEPFAR was not cancelled completely. The idea was that the funding for the drugs would remain, but the funding for the services and prevention, everything else would go. But it's not clear that the funding for the drugs is getting through either. Wow, that's powerful. You could be responsible for killing 6 million people. And it's not just health aid. The United States contributes 65% of the budget of the International Organization for Migration, UN High Commissioner on Refugees, the World Food Programme, more than half their funding, UN Population Fund, International Rescue Committee, International Red Cross. I mean, that 25% of WHO's funding that's been taken away is causing absolute chaos in WHO. Save the children. So if the US stops all of this, the impact on the social determinants of health will be huge. Now, you could say it's taught the global community a lesson. Don't be so reliant on one dominant player. Yep. But there can be a lot of pain, and a lot of children will miss out on school meals because half the funding of the World Food Programme is under threat. Before the AIDS cut, the US funded 70% of the global HIV/AIDS response. US contribution, the non-US contribution, not receiving care. This is women receiving HIV treatment to prevent transmission to children. HIV patients receiving HIV therapy, overall global HIV/AIDS response. What a threat to global health. How can I talk about hope when I've just shown you that? Well, there are grounds for hope. I said to you that I'm co-chairing the Global Council on Inequality, AIDS and Pandemics, that Winnie Byanyima, the head of UNAIDS, set up. Here we are launching the Global Council in Brasilia. We met with the G20, my co-chairs, Joe Stiglitz, Nobel Prize-winning economist. That desperate-looking person is me. Monica Gangos, the former First Lady of Namibia. And the G20. The G20 said in their declaration that in order to prepare for the next pandemic, you need to invest in the social determinants of health. Wow. Grounds for hope? Yeah, that's grounds for hope. My co-chair, Joe Stiglitz, last year published his latest book, The Road to Freedom. He said, neoliberalism has run its course. Now we need the road to freedom. It's an answer to Friedrich Hegel's The Road to Serfdom, which in a way ushered in the neoliberal era. And in the UK, people ask me, aren't you frustrated that no one's listening? And the answer is, people are listening. These places, more than 40 places, in fact now 50, have declared themselves Marmot places. We're doing a national strategy for Scotland. The Minister of Health in Wales announced 10 days ago, 2 weeks ago, that Wales will become a Marmot nation. Coventry was the first. They declared themselves a Marmot city. Greater Manchester, Cheshire and Merseyside, all around the country, Lancashire and Cumbria, Luton, a Marmot town, Waltham Forest, a Marmot borough in London, Leeds, a Marmot city, Gwent in Wales. What does it mean? They're taking my 8 domains of recommendations that I showed you earlier and are applying them at the local level. And we've got business involved. Big insurance company, Legal & General, asked us, what can business do? So we produced a report saying the business of health equity, the Marmot Review for Industry. 3 things we said: good quality work, pay and conditions. Every employee should have a real living wage. Goods and services. We hear a lot about the commercial determinants of health. If you're producing goods that are damaging health, then you're not part of the solution, you're part of the problem. The question is, for example, if you're the food industry, which side are you on? Are you going to help us by purveying healthy food? Or are you going to be against us by making the world overweight and obese? And the impact on communities, employment practices, environment, and the like. When the leader of the Labour Party before the 2024 election was campaigning, he launched a health mission. And in the supporting document, it said the next Labour government will amplify the approach of Marmot cities like Greater Manchester and Coventry by making England a Marmot country, tackling the social inequalities that influence health. Well, we're waiting, but I'm hopeful. I say I'm hopeful. Often I get asked, are you optimistic? Optimism and pessimism imply certainty. Optimism, well, you know things are going to get better. Pessimism, you know things are going to get worse. Hope is fear's opposite. I was invited to Northern Ireland, so I looked up an Irish poet, Seamus Heaney. He said, history says, don't hope on this side of the grave. But then, once in a lifetime, the longed-for tidal wave of justice can rise up, and hope and history rhyme. Yep, we're looking at the world and saying there are a lot of reasons not to be hopeful. I think we have to work together to make this a moment where hope and history rhyme.
So, Professor Marmot, thank you for your insightful presentation. So let's follow up with the Q&A session. It's an hypothetical question. If I just have enough option to choose for my next birth, I should choose to be born rich in developing country, or I choose to be born poor in a developing country?
Well, the worst option is to be born poor in a low-income country. What we know, if you look at life expectancy, for example, by education, we did this in Europe, that if you're going to be born poor in a poor country, make sure you get a university education. Because when we looked by education, the inequalities were bigger in poorer European countries than they were in richer European countries. But that was largely because of the poor health of people with low levels of education. So the country variation for people with university education was much less than the country variation for people with only primary or secondary education. So in general, if you're going to choose where to be born in a country that's relatively wealthy. It doesn't have to be Qatar or Oman or Saudi Arabia, very rich countries, or the United States. I mean, the US would like Canada to become the 51st state. If you're Canadian, you're better off to be Canadian, because life expectancy is longer in Canada than in the US. No question, you're better off to be born poor in Canada than poor in the US, despite the fact that the US is 20% richer. So it's not just the overall wealth of the country that matters, it's the social determinants of health and how that wealth is distributed.
Thank you, Professor. Another question is, does health insurance contribute to public health and health equity? And if your answer is yes, then kindly explain, please.
So does health insurance contribute? Was that the question?
Yeah.
So as I said, my primary concern is with the social determinants of health, not with the health care system. That said, when people get sick, they do need access to healthcare. Quality and equitable access are key features of a healthcare system. So yes, it matters. And as I often say, to the insult of poor health because of inequalities, you add the injury of lack of access to quality healthcare, you've made the problem worse. And we know from bitter experience that a market is not the way to get, in healthcare, is not the way to get optimal allocation. A single payer system is much more likely to get optimal allocation of resources or some form of public subsidy. So to make sure that everybody gets access regardless of ability to pay.
We have the last two questions, Professor. The first one is, what according to you is the biggest issue for public health? It is the economic burden of disease or the lack of management of the available resources? That is the first one.
I mean, it's interesting. In Britain, there was a survey of public health people of what the biggest contributions, the most important contributions to public health had been in the 21st century in the UK. And they said restriction of smoking in public places, the sugar levy, and the Marmot review. So in other words, interpreting that, they're saying public action. So you didn't need a lot of resources to get restriction of smoking in public places. That took social action. You didn't need a lot of money to get the sugar levy, to restrict, to tax high sugar products. And I would say to implement the Marmot review, these 50 places that have become Marmot places in England, they've all suffered brutal cuts to their funding, as I showed you. The cuts to local government funding have been brutal, but they're operating nevertheless. So money would be helpful, no question. Funding would make a difference. But we don't have to wait for lots more money for action to happen. It's actually a good use of available resources. So that's an evidence-based response.
Thank you. And another question is, what initiative or changes have you seen or can suggest will contribute to becoming a Marmot city or a Marmot country?
Well, the biggest thing is you've got to want to do it. I mean, you know, that's number one. You've got to want to do it. You've got to say, we see as vitally important improving the conditions of life for the people who live here in the city, in the region, in the country area, or in the country. You've got to say, this is a priority for us. I've spoken to people not only in England, Wales, Scotland, and Northern Ireland, but in other countries. And there's real interest, which is the first. You then do need some resources and organization to make it happen. But we've got an evidence base. So when people say, oh, inequalities in health, they're related to inequalities in society, it's so complicated. You know, where do you start? And my answer is, here we are. We've broken up into 8 principles. You don't have to do them all at once. You need to consult with your local population so that you get bubbling up from the community what the priorities are. In practice, they're closely linked, the 8, but it needs to respond to local priorities. So the political leaders have got to want to make it happen. Then it's vitally important to respond, to have a way of building on lived experience of people in those areas. And then it can happen. You need the technical know-how, which we can help with. And it's very important to work with local experts and deliverers of services. I mean, we took a high-level delegation from Canada off to Torven in Wales, this tiny host mining community, this tiny community in Gwent. Welcome to Torven, a Marmot community. The director of social services is intimately involved in making this a good place to live. The young people, the teenagers, were showing us around because it's now become a World Heritage Site. This is where the male choir used to meet. This was the chapel, this was the co-op, this was the mine, and so on. They've got the community involved, they've got the director of social services involved. It doesn't have to be a rich community, but it's got to get engagement of all the key sectors.
So thank you so much, Professor Marmot. On behalf of the World Federation of Public Health Associations, we are honored to have you with us. And to all our participants, thank you for being part of the important discussion. We encourage you to stay engaged and join the upcoming webinars this week. Each one will bring a new perspective on how we can build a stronger, more equitable systems of public health. To learn more about World Federation of Public Health Associations global initiatives, visit our website and follow us on social media. Thank you once again, and we hope to see you at the next webinar. Thank you so much.